Our Constitution states that everyone has the right to have access to healthcare services, including reproductive healthcare. In his address at Women's Day celebrations in Pretoria, President Cyril Ramaphosa says the health of women must be a key priority. Access to healthcare and support for survivors of gender-based violence are just some of the challenges still facing women. And to discuss this, we spoke to Dr. Tlaleng Mofokeng, the UN Special Rapporteur on the right to health.
I think a day like today, it means a lot because it provides us a moment to reflect and to see how far we have come in terms of demanding our rights as women, as people who are fully participating in the anti-apartheid movement and as equally as men were. And I think a day like this is important to draw the spotlight on the activism and the advocacy of women, particularly in an anti-apartheid South Africa, and to think about what does a democratic South Africa look like that really does pay attention and take the needs and the rights of women and girls seriously.
And, you know, the president earlier on saying that women's health outcomes continue to improve as a result of progressive policies around reproductive health. And I'm borrowing from him, saying antenatal care, HIV, AIDS and other communicable diseases. But he also continues to say women still carry the largest burden of HIV and are most vulnerable to sexually transmitted diseases. And I wonder, because if we're still having a conversation like this one in 2023, is this a fight that is being won, or are we stagnating?
Look, I think what we need is actually more disaggregated data, because it's really good on a global level for a country, for a region, and for the world generally to talk about improvements in statistics and in data. But really the detail is where we need more information, because you will find that even in the United States, even the United Kingdom, even in South Africa, it's still Black women who are still experiencing higher maternal mortality rate. Their children are still dying preventable deaths in the neonatal period, and it's still Black women's children who are dying at the age of under 5 from other preventable diseases like infectious diseases. And so we really do need to think about also issues of poverty and other intersecting issues such as sex work, such as being a minority or a person seeking asylum or a refugee in a particular country, because all of those do determine whether you get access to services, whether you get access to information even, or goods, or even the clinic or hospital that are so desperately needed for many people in vulnerable situations.
And it's still even Black people, Black women, in fact, as you say, who are finding themselves even in spaces where they're marginalized, and sometimes they are in rural areas. They cannot even access some of these healthcare facilities, and some of them are waiting months even for just a thing as a diagnosis in order to know what they're struggling with and to treat. All right, it does sound like, it does look like Dr. Tlaleng is frozen, just her picture's frozen a little bit. Dr. Tlaleng, I hope you can still hear me.
I can hear you. I don't know if you can hear.
Yes, now we can hear you. I think it's frozen once again. Oh, you're back now, you're back. And I was saying that as we talk about, the data and the importance of looking at what it all means, it's also Black women who are finding themselves in rural areas who are struggling to even get to a healthcare facility just for a diagnosis, to know what they are battling in order to treat it.
And what you are saying is very important, because the right to health as a human right is defined as not just accessing healthcare, but it talks about underlying determinants of health. And infrastructure such as roads, water, electricity are really important to enable access. It enables access for individuals, like you say, to be able to move from where they are to go to a health facility, but it also enables them, when they get to a health facility, to actually have quality care. Many instances, people are doing these long journeys to a hospital or a clinic only to find that there's no electricity. So even if as an individual they've done everything they can to seek care with the information they have, the system still fails them in that they're unable to actually receive the service in a timeous manner, in a language that they can understand, in a way that actually affirms and recognizes their dignity as an equal partner to be able to direct the kind of care that they should be receiving as well.
And especially, you know, one of the things that breaks my heart is when in some of these instances, the women themselves are at the mercy of a healthcare worker who doesn't understand the rights that they have to, you know, sexual reproductive rights, for example, and the conversations that they should be having with them. And if a healthcare worker doesn't feel like, you know, giving you some of the treatment in this particular regard, we have young women who are opting to not go for this because they're not being heard.
Absolutely. And not only is information necessary from a patient's point of view, but good evidence-based medicine and care is fundamental to upholding the right to health. And so I always advocate, and for the last 6 years, have been doing extracurricular training for healthcare workers, including doctors, as well as nurses, in human rights and health, because I recognized even in my own undergraduate training that there was a missing link between human rights and health, and how in my daily practice as a medical doctor, I'm actually promoting and protecting and fulfilling human rights. And I think it's that paradigm shift that we need in the medical curriculum, in the medical training, and in the ways in which we treat patients, to see them as equal counterparts in their journey of their health and wellness. But we also have to recognize the discrimination, the coercion, and the violence that many of our patients already come to the hospital and the clinic having already experienced. And so the clinic or the hospital cannot be a place that further perpetuates violence or discrimination or coercion. We should be the ones, and often we are the ones, who are first to hear and witness some of the things that happen to patients, and therefore we must be cognizant to a human rights-based approach to care.
And you know, at a practical level, I wonder how does one begin to do that? Because, you know, this is a huge issue that you speak about, because a lot of people who are coming, as you say, are traumatized, and they're hoping for an ear that is going to comfort them, that is going to, you know, give them a sense of hope as they're looking to be able to get access to medical health care. So how do healthcare workers at a practical level begin to do this?
It's an important question, because there is a resistance to review the medical curriculum in the ways that we are taught, but also in the content in which we are taught and in the environment. So medicine is very paternalistic. You've got the doctor who's got the power and the knowledge, and they are the scientists and the experts who knows everything, who can diagnose you and therefore prescribe and tell you what to do. And we use words like patients to describe people. Where does the word patient come from? What are you being patient for? What is it that you are anticipating that you will then have this perfect model of a patient who will then be rewarded with dignity and being treated well? So there's a whole lot that we really have to go deeper into around even the issue of coloniality, around infectious diseases, and how we talk about people as burdens, right? We talk about the HIV burden. HIV is not a burden because you are implying that people are a burden because HIV is within people, right? So it's just even in the terminology. And I don't think the medical fraternity is ready to have the conversation, because it would mean we have to interrogate our own power in that hierarchy of doctor-patient relationship. And I'm not sure many of us are willing to do that as yet, because it requires us to actually have respectful and understand that patients ultimately retain their autonomy no matter what illness they have, whether it's mental, whether they need a sexual reproductive health procedure like an abortion, whether it's someone who's a sex worker, whether someone who's a drug user. I mean, we really need to change how we think and how we are taught ourselves, and not be paternalistic in how we approach patients and care. But that takes a whole paradigm shift.
And I suppose then that will also make the dynamic shift, you know, a bit more easier, because a patient will be able to be empowered and know that they can even ask questions and have an empowered session with a doctor, as opposed to a top-down approach.
Absolutely. And that creates a conducive environment where patients can share with us their thoughts, their feelings, their dreams for the future, their perceptions of their own lives. You know, often we say patients are non-adherent to treatment, but what we actually mean is that patients are not doing what we say they must do as doctors by when we say them, but by having the time to listen to patients' ideas and perspectives on life, we can actually understand why their course of illness and their choices are what they are. But this requires that we have a lot more nurses and doctors in the system than we currently have. Unfortunately, the things I'm talking about requires us to have longer consultations, to have conducive environments of work ourselves, that our own mental health is taken seriously as well. And so it can't just be a one-sided approach. We have to do everything at the same time to get the desired outcomes. But it's really important to center the fact that the healthcare system has to be a conducive environment that's holistic, that's not just looking at disease treatment, but health and wellness and prevention as well.